cases globally of COVID-19 and nearly 218,000 deaths. So it's quite a statement. Focusing on Africa, I'll say as an aside, unfortunately as well, the US is still leading the number of cases, as I'm quite sure you have an awareness about, and the countries around the world in Europe have not changed a whole lot in China. But really focusing for the moment on Africa, it's interesting that right now the top 5 countries are Egypt, which has over 5,000 cases and 359 deaths. And it has moved up in the ranks since mid-month when the Africa CDC reported out its data. South Africa is now second with nearly 5,000 cases and 93 deaths. It had been first mid-month. Morocco, followed by Morocco, Cameroon, and Algeria is in there as well. Big countries like Nigeria, last reporting had about 1,532 cases. DR Congo, 471. Many of our colleagues here from in Kenya and Tanzania areas, 374 cases and 299 cases. So we're seeing changes now starting to go forward throughout the African continent. It does appear in the figures when you look by region that it's the northern part of the continent that has the largest number of cases and higher case fatality rates. We are seeing difference in case fatality rates in different parts of the continent, different parts of the same country across the world. Interestingly, at least from what I can find, 42 countries in Africa are noting local transmission. 9 have imported cases only. 43 of the countries there had full border closures. A few other countries before I skip to some other important findings. Looking around the globe, India, 31,300 some cases. Indonesia, 9,511 cases with 773 deaths. Philippines, 7,958 cases. Quick snapshot of around the world. We'll hear more about Peru, so I'm not going to focus on South America. My colleague in Kenya, Patricia Odero, had some important sharings from you. Her showed that testing strategies have not really been fully ramped up in much of Africa, but South Africa is now up to 10,000 tests per day with community-based contact tracing, while Uganda is focused on key segments, including long-distance truck drivers. Countries are battling with the decision to reopen with unclear strategies and pathways, so they're not alone there. Ghana reopened after a 3-week partial lockdown, and since then reported significant increase in cases. There continues to be a lack of clarity on treatment options, and Benin recently announced that chloroquine is part of its treatment strategies, as have. All right, I'm back again. I seem to be having bad luck every time I try to report. Am I back on? Am I back?
Yep.
Okay. I wanted to share a really important resource that PATH put together. It's called Resources to Support COVID-19 Responses in LMICs. We'll be glad to share the reference, but it has sections on disruptions to essential health services and non-COVID deaths. So we're finding globally, as we have with past pandemics, that many people are dying from more or less routine causes because they either are not seeking or not getting the essential care they need. So service disruptions is a major cause of those excess deaths happening along with COVID. It has key technical and policy guidelines for LMICs. It has information about maintaining those essential services, evidence-informed policymaking, and data-driven decision-making. We'll be glad to share that reference for those who are interested. I also found some rapid success stories, if you will. Interesting, it was from NPR that noted what's happening around the globe and reinventing factories so they can make medical equipment given the need for more supplies. In Kenya, the textile industry has pivoted to making masks and protective equipment. And also their state-owned oil company is now making hand sanitizers, which it's distributing for free. In South Africa, the state-owned missile manufacturer, Denel, has been working to design and build ventilators and to convert armored trucks into ambulances. So there's really important things happening as well in very basics like hand washing stations. Liberia, Sierra Leone, have been setting up these public hand washing stations, as they did really when they were fighting Ebola. Also in migrant camps in Nigeria and even health facilities in Mozambique have been setting up these mobile hand washing stations to help their workers and protect their patients. On a pragmatic side, the World Bank is now using a dedicated fast track facility for COVID-19 response, and they are mounting $1.9 billion and to assist 25 countries. They expect to deploy up to $160 billion over the next 15 months. So stay tuned and be working with your World Bank colleagues. The first installments are going in Africa. One program in Ethiopia will receive about 82 million to address preparedness and response. And in the DR Congo, 47 million to put in place containment strategies and training. I'm going to finish up with a very important article again. Those of you who have time, it's coming out of the Imperial College. It's one of the first I've seen that's focused on strategies for mitigation and suppression and compared impact globally around the world. They've estimated that without any interventions, we would have had 7 billion infections and 40 million deaths globally this year. But what I like is they've really analyzed, particularly with an emphasis on LMICs, and looking at factors in terms of the demographics, as well as, of course, the underlying health system status. But they've looked at things quite importantly in terms of transmission, including household context and the mix between the ages potentially within those households. It's got a lot of very good graphics. It's well documented, and there's an amazing table that you should definitely look at by region that shows the unmitigated scenario and then 2 different forms of suppression, which can save really thousands and mitigate infections for hundreds of thousands. So with that, that's your roughly 5-minute update, and back to you, Judd.
Great. Thank you, Diana. And it is my pleasure to introduce Dr. Antonio Quispe. He is currently advising Peru's Ministry of Health as a member of the National Prospective Committee for COVID-19 relief efforts and working on 4 studies that aim to improve Peru's preparedness and awareness against the SARS-CoV-2 outbreak. Dr. Quispe is a research professor at Universidad Continental School of Medicine and at Universidad de Ingeniería y Tecnología, both in Peru. In addition to a degree in medicine from the National University of San Marcos, Antonio has a master's in epidemiology from Universidad Peruana Cayetano Heredia and a PhD in epidemiology from Johns Hopkins School of Public Health. Welcome, Antonio. Thank you so much.
Hi, how are you? Thank you so much for the introduction. Let me attempt to share my screen. If everything goes well, that would be awesome. Give me a second. You need, okay. There you go. It looks okay?
Yep, looks great.
Hello, thank you for introduction. Thank you for having me. Let me go through the slides, and we're trying to give a glimpse about the innovation in pandemic time here in Peru and grasp the scope of the current situation and try to tell a little about the story behind Peru relief efforts against COVID-19. So three aims. Let's go through the theoretical framework, go through one example about how to respond to the challenge of assessment of adherence to quarantine, and finish with technological innovations in pandemic times. First, one question we try to go through is, what is the theoretical framework to deal with COVID-19 and how we could countries and South American countries respond to this pandemic? And the answer to this one, there is none. Basically, we start from scratch. It's a new disease. We don't have a clue how to fight against it. And we try to develop knowledge in progress. And that is something that is really striking because we're having major troubles to assess, to measure, to respond, to save lives in every corner of the country. And one of the things we're trying to do is try to use technologies to make more effective our interventions and try to plan properly and take the best decision as we can and as informed as we can. So this is something that we start to doing across the country, and this is a major problem because Peru is a very centralized country. So we have Lima as the capital, and before and after that, all the indices you can assess is going down in poverty, in assessment to quality healthcare, etc., etc. So here's something we start with, and this is a scenario we the government start the mobilization restrictions in March 16, and as soon as we fail miserably to actually convince people to accept these kind of measures. This is a set of a qualitative study of 128 photographs across the country from 25 regions, and we noticed immediately that the restrictions of mobilization fail in every single market. So supermarkets, markets, street markets, anything you can measure, and you will notice immediately that people didn't accept the mobilization restrictions accurately. So we started with a very, very high speed of progress of COVID-19. The first assessment is starting to duplication in 3 days, and we're implementing several measures to stop that speed of growing. And that daily growth up to April 9, 2019, it's basically new cases are duplicating in 10 days, death by all causes are duplication in 5 days, cases in critical intensive units are duplicating in nine days, and deaths by COVID-19 are duplicating in 10 days. So here you need to pick huge difference in the amount of deaths we're counting by all causes and the ones that are attributed to COVID-19. So you notice that the curve is pretty much going up to flat, and that means that the deaths by COVID-19 are duplicated by every 10 days. That sounds really great, but what's happening below that is that the deaths by all causes are increasing rapidly. So this is something has been reported in pretty much every country, but it is very highly variable. So in the case of Peru, we are having a big trouble trying to assess these particular differences and how to complement the primary care across the country, which is a major limitations in region by region, capital by the rest of the province, etc. etc. So this is the mathematical modeling of the reproductive basic number. So we started with an estimate of 2.8, and pre-intervention, there is something little happening in terms of intervention to reduce the transmission of COVID-19, and we have a range between 1.2 to 2.2. So the government launched a series of interventions called the first hammer, which basically it was restriction in every border, restriction in mobilization across the country. We started with toque de queda, which is something like stop every kind of mobilization in particular days of the week, and so on and so on. So after that, we estimated that the RT go down to 0.9 to 2.3, and this is pretty much variable across the country. And then we recommended to increment to extend the restriction of mobility and also implement other interventions like case isolations inside the households, outside the households. We started to do some cluster containment and so on. So we pretty much estimate that the RT go down to 0.4 to 1.3. So in terms of using remote sensing technologies to assess the crowding in the primary markets in the country, we actually use the Peruvian satellites, which is the Peru Sat. And with that, we made polygons across the country in the major streets, so we can actually measure how is the reduction of street traffic in this particular point. So we pretty much measure over 2,000. And then also we do the same in the markets and try to go through qualitative measures, quantitative measures, remote sensing specific measures in the distance between people, and so on. So here's an effort to use mobile phone antennas, which is pretty much spread across the country, and we can actually assess how many mobile phones are linked to one antenna at that particular time, and how many into the next one. And also we use centroids the location of the markets, relocation of the banks, and the locations on small markets also. So we actually have a glimpse about how are the human mobility in the peak times and every day. So here is the Google report about Peru, a reduction in terms of adherence to quarantine. And you can notice immediately that is a very, very large reduction. Peru's mobilization restriction is one of the highest across South America. And this seems to be very good because it's a very structural intervention with a huge impact in terms of the decrease of the speed of growing of COVID-19 across the country. But you will notice also that there is some small peaks in the course, which means that there are particular days in the week that the mobilization restriction going down. And this is pretty much the market states. If you compare Peru using these indexes to the other countries in Latin America, Peru is one of the countries that have the highest adherence to quarantine and mobilization restrictions across markets and across recreation sites. So here's an effort to assess the traffic street traffics, and this is the measure of NO2, and you can notice that the heat map is going particularly variable across the country, and this is because Peru is very centralized across Lima. Even in the region of Lima, the capital, the Lima district is having higher traffic, and you can notice immediately that was the one to go down further than any other areas of the region. So here's an effort to assess the adherence to quarantines using heat maps, but this is from accounting for every case, for every location, and every report of suspicion cases and confirmed cases. So basically we try to assess the question about how is the variability of adherence to quarantine using every measure we could have against them. So we use qualitative observations, statistical modeling, remote sensing, cell phone tracking, NO2 concentrations, even drone surveillance to actually we measure in 30 markets, or the main markets in the country, to have a glimpse about how we can reduce the capacity of the markets and how actually intervene most of those, the ones that have the district with the highest amounts of COVID-19 cases. So this is one of the scenarios. So we did the same thing for every kind of question you can imagine, and we go through a set of slides that's pretty much classifying every aspect of the COVID-19 interventions. So from the perspective of epidemiology, diagnostic, communication, prevention, treatment, and post-pandemic scenarios. So in terms of epidemiology, we use telemedicine and consultations and follow-up, clinical and emotional, through call centers across the country in every regional health directorates. We use tracking individuals to contact tracing algorithms to try to assess how is the rate of transmission and in particular locations in the country. We use several statistical modeling, forecasting, and heat maps to inform the health workers where to go at what particular time and what exactly to do in every site, in every district, according to the distribution of the cases. We are going through a massive program which is called Cuido Peru, which is taking care of Peru to isolate positive cases inside the households with the particular conditions and outside the households using the previous construction from the Pan American Olympics. So this is something that it was kind of the Wuhan hospitals that was built in 10 days, which Peru had already a beautiful building with a massive capacity to do the same. So we transform those buildings in hospitals, and we transport those buildings in kind of temporal isolation facilities for people who have particular conditions that they cannot stay at home. So we use contact tracing algorithms. We use apps to rely supports for quarantine, particularly for the people with psychological problems, to have some kind of backup from in pandemic times. And we use very different tools in surveillance. So you can see in the graphics, the upper graphics show particular clusters in the district of Miraflores, and you will see in the middle that the specific location of the cases, and you will see below the variability in the size of the clustering. And you see in the below, you will notice that there are more like 3 cases with a single duration. So we notice immediately that they have a Pareto distribution, and then we have a specific location with over 52 cases linked to one. So this is the vertical construction of the buildings. So if you have one particular direction with large amount of cases, that's probably a quinta, and a building, a residential facility, and so on. So this is prevention. So in terms of prevention, we close our borders, we implement social distancing, we do quarantine, we are currently doing case isolation and cluster containment, we are working on risk communication, we try to deploy common solutions for as disinfectants for people at every socioeconomical levels, massive disinfections, and we're actually moving towards UV ultraviolet lights. And there is a particular experiment that went really, really wrong with using H2O2, and we're developing masks and face shields in massive amounts. So in terms of diagnostics, Peru spent a lot of money on rapid tests, and we didn't stop to do molecular testing. We're working towards serology right now and trying to implement massive diagnostic like Malditov and Gene Experts, and there is also an attempt to do microarray tests. We assessed the market, and there are 423 commercialized brands, but none of them have, most of them don't have any kind of validation studies out of 518 developed. And this is the concept of is giving a hard time to assess what is the best criteria to return health workers to hospitals after infections, and this idea of immunity passport that was outside for a long time without any current answer. So in terms of treatment, there is no vaccine, there is no pharmacological treatment, but there is no pharmacological alternatives like mechanical ventilators. And there is some reports about ozone therapy. We want to towards clinical trials around here. So the current pharmacological treatment includes corticosteroids, anticoagulation, we're assessing ivermectin, and like many other countries, antivirals. In terms of scientific communication, I was particularly involved in several projects of this. This is the infographic from the Conciencia project. They were doing the Journal Watch, and the Peru is using the electoral frame, which is a very, very expensive frame in radio and television and newspapers. So that particular frame is currently used for COVID-19. There is an application called Peru en tus manos, which includes a model of digital triage we're using to actually use as a clinical chart. And this is very cheap, and it's a massive use of this application across the country allowed us to use contact tracing algorithms and to use algorithms to predict severe and risk of dying. And we're actually moving towards songs and stickers and social networks interventions like that. And this is the thing that scares us the most. So pandemic situation and the current problem of Peru between the leverage in the amount of dead people with the risk of breaking the country in terms of economics. So that is the current challenge we're facing with. And the government is extending the quarantine for 14 days after the first 10 and 32nd 10. So we are at the risk of having the major recession in the history of the country. So that's bad news. And we're really, really close to the peak of the curve. So we're pretty much at the large amount of deaths and the large amount of damage, at the mass amount of people that are going broke, and so on. So it's not an easy time here in Peru, and we're counting already over 800 deaths. And that's pretty much at the risk of the top of the medical attention capacity. So we are pretty much at the age of the hospitals to go below the amount of availability of beds for critical intensive care units with ventilators. So we don't have a theoretical framework, it's work in progress, but we're pretty much Peruvian, so we're really resilient to many other things. So this is the kind of graphic the president presented for the first time. and we're a country we're fighting really, really bad to reduce the amount of dead people. So this is what we're doing so far. Thank you so much for your attention.
Great. Thank you, Antonio, very much for that presentation. Do we have any questions from the audience? Feel free to unmute your mic or use the chat function.
Hi, Antonio. This is Ernesto. Thanks for the great presentation. Do you could you explain really quick what are the plans for? Is the country already having plans to open the economy or start relaxing a little bit some sectors of the economy to avoid that that recession and collapse of the economy?
Yes, so there are a very strong call to move towards that, and we did several projections trying to characterize the epidemics at every region. So you can imagine there is like 4 regions that already go beyond the peak and actually over the capacity to attend those patients, which includes Iquitos, Lambayeque, La Libertad, and Tumbes. So those 4 regions are really having a hard time right now. But there is some regions in the south of the country, particularly in the highlands, with very small amount of deaths. So the idea of Peru having a strong mining economy, so it actually induces large mining companies to open, and that also was linked to small outbreaks. So it's kind of hard to advise against it, but the Ministry of Economy and Finance is already having a plan, and we're advising to assess when to start that. And the current advice is to go after 2 weeks in decreasing the trend. So you can use that, that would be awesome, but we know that we cannot wait to that. And you notice that in the last 2 weeks, there is a humanitarian crisis between people that don't have any money to eat. So they're trying to return to their regions of origin, which is a major problem. So you can imagine from an epidemiological perspective, how this higher risk of increasing the contagiousness of the disease and the transmission intensity and that sort of stuff, for moving people from areas with high counts of deaths and cases of COVID-19 to regions with very small amount of cases. And we cannot stop that. We're actually trying to implement temporary isolation facilities in the road. So that is also some intervention we're trying to implement in the meantime. So yes, there is a plan. We are advising the best way to implement it. And we have already thinking to open primary economical activities, and particularly focusing on the regions with very small, where the epidemic is just starting. So I can show you the maps and the projections, but you can split the country by half. One half is going to have hard time soon, and the other is just starting the epidemics, and we're looking forward to save as many lives as we can.
Thank you, Antonio.
Any additional questions for our guest? Thank you once again for your presentation. We appreciate it very much.
Yes, thank you guys for the opportunity. Have a good one.
I'm going to go ahead and share my screen. So the next point on the agenda, where we're going to invite some innovators to do flash presentations. on solutions that they have developed and they would like to share with the network. And first up is Noora Health. Arjun Rangarjan is going to be presenting their findings. Arjun, are you there?
Hey, Jed, I'm here.
Okay,
Would you like me to screen share?
that would be great.
Okay. Morning, everyone, and thank you for joining. So I represent Noora Health. We're a nonprofit based out of India, and we work primarily in India and Bangladesh. Really happy to be here sharing some of the work that we're doing, and hopefully this will be of help and use to a lot of you. Broadly, what we focus on is patient and family caregiver training and education. Our goal really is to ensure that family members who ultimately end up, usually being the primary caregivers, have the right tools and skills to help improve outcomes for patients and improve the care journey both for family members themselves as well as for patients. And we do this by providing key skills that they can take home post-discharge or post-interaction with the health system, and really drawing on those crucial moments. We do this through a number of ways. We collaborate closely with the government. We develop content that's design thinking informed and really patient and family centric. This is all in the vernacular in many languages in India. We train existing healthcare staff to deliver these trainings and kind of follow up digitally over WhatsApp, and really continue to provide that support over the behavior change journey, regardless of the clinical content that we're teaching on. And we do this across a number of different clinical areas. I mention all this because we've been able to sort of take these learnings that we've had over the last 5 years and really put it to use for COVID-19 and in our COVID-19 response. So just to give you a sense of where we work and what we do, we have programs established across 7 states in India, as well as pilots launching in Bangladesh. The states are listed, and our sort of loci of where we normally function is at the district hospital level. And so these are public healthcare facilities in towns and smaller cities, sometimes larger ones too, but spread across the states you see in yellow. I mentioned this because some of these hospitals are still functioning. Some of them, have nurses and other healthcare workers still, turning up for work. And of course, for instance, one major area we work in is maternal and child health. And of course, women are still having babies. And so much of the education that we provided in the pre-COVID, sort of scenario is ongoing. But what we've done is to try and incorporate and integrate as much learning and knowledge sharing as we can for those individuals, for those healthcare workers who are still in place and, still interacting with patients and still have an opportunity to drive some of that health behavior change. So just, kind of thinking back to that health behavior change journey, what we've really done is to shift our focus to ensuring that accurate information is reaching the most number of patients, the most number of communities who are at risk in a timely fashion, and that this is credible, verifiable information based on evidence-based knowledge, and really ties in with local governmental, regulations and guidelines, and is sort of impacting specific groups as well. So you'll see that, we've developed content that's specific for women in pregnancy, for, thinking about new moms who are also anxious at this time of COVID and really wondering how is it going to impact them. A lot of what goes into our content is sort of learnings that we're seeing, not just from our existing healthcare workers who are still on the ground, in terms of our government partners, but also sort of a large needs finding exercise. And I'll talk a little bit more about this later. But we've developed content across audio, so it can be used in, sort of IVRS settings, recorded messages that can be transcribed and shared, video, and these are all optimized for digital delivery. For instance, in India, WhatsApp is widely used. And so disseminating our materials over WhatsApp makes it really easy to sort of share and utilize. We're also making all these available in 8 different Indian languages and available for download on our website. So if any of you work in India or have colleagues who work in India or could use materials in any of the languages that we have up, these include, Tamil, Hindi, Marathi, Bengali, Kannada, Telugu, a number of others. I won't go into it. But essentially, we have these health behavior change modules that we call them, and these are similar to what you see here. So each of those tiles has additional material across audio, video, and infographics, which can be customized to a certain extent and utilized based on need and setting. So I encourage you to go check them out on our website. Like I said, these are available for download. If you have further custom needs or questions, you can always reach out. We're happy to pursue conversations about how we can make them more targeted and more high yield. And as the sort of pandemic shifts and the phase really of what's happening on the ground changes in India, we're also trying to incorporate learnings and sort of needs on the ground in terms of what's most relevant now, working into the fact that lockdowns are being gradually phased out, but still trying to anchor on the most important health behavior change messages that will still be crucial regardless of whether lockdowns are in place or not, especially thinking about sort of continued transmission and community transmission. We also, as I mentioned earlier in the piece, kind of have a number of different verticals. The content is one, and the digital follow-up is another piece. What we've been able to do in Bangladesh is launch Bangladesh's official WhatsApp chatbot. And so this is a number that anyone on WhatsApp who has WhatsApp in Bangladesh can text. They'll get a menu of options. It's based on the WHO chatbot that many of you may have seen, that was developed by Practical and Turn.io, who are South Africa based, and we work with them closely to put this together. They are open to conversations, and I'm happy to sort of facilitate connections. They are open to conversations for developing this in multiple settings, but prioritize collaboration with state or central governments. And so this tool here that you see launched last week, we've had 10,000 users on it in a couple of days, 100,000 plus messages going out. And it's all, again, based on WHO recommendations and Government of Bangladesh Health Ministry recommendations, and provides, sort of two-way communication in addition to key information on these many menu items that kind of scroll through as you interact with the bot. We have a research response that helps us meet some of these needs and learn on a more ongoing dynamic basis. I won't go into it too much, but we're constantly seeing interesting insights from the ground. Again, this is a report that we've now put out 2 versions of, speaking to over 2,000 people across India, including healthcare workers and community members. You can find them both up online. The link is in the slide, but I can also share them, and I think they're on the Learning Collaborative Network as well. So just to summarize, that should read 16 health behavior change topics, not 165. But we have 16 health behavior change topics in these 8 languages. They're all available for download. We're currently disseminating these out in collaboration with 15 partner organizations, both nonprofit partners, as well as in some cases, state governments. I mentioned the survey, and the last piece really is we have an ability to also train either the staff of other organizations or reach out directly to community members to provide training. And this could be specific to, high-risk populations, elderly populations, populations with a specific need where it would be helpful to reach out over the phone and provide a service that's targeted at them. And these are all sort of resources that we have in-house that we've been able to redeploy in some sense towards meeting the COVID-19 sort of need and response. So I'll end there, and I'll take questions. Yeah.
Great. Thank you so much. For the sake of expediency, we have 2 other speakers we'd like to bring on. So I'm going to ask folks if you could use the chat function to ask questions of Arjun. That would be great. And I would like to invite Tara Talvakia from Attorney Foundation. Sends her regrets she can't join us this morning. Hopefully she'll be joining us in a couple weeks. So next up we have Cynthia McKenney from Project ECHO.
Great, I'm going to share my screen. Hi, everybody. Can everyone see that?
Yep, that looks great.
Great. Well, thank you so much for the opportunity to present Project ECHO. Project ECHO was started back in 2003 by our founder, Dr. Sanjeev Arora. At the time, he was the only person in the whole state of New Mexico. We're based in Albuquerque at the University of New Mexico. And he was the only physician that was actually treating hepatitis C, which, if you know much about that disease, it's largely in underserved populations. It's about 50% of the prison population, a lot of rural, particularly it's at epidemic proportions in the Native American population. And so there was an 8-month wait to see Dr. Arora, and people were literally dying because, and this is a disease that could be treated. And so out of that, Project ECHO was born. And Project ECHO is, the model moves, oops, sorry, I meant to go here. Project ECHO improves access to quality medical care and disseminates best practices to clinicians and other healthcare providers in rural and underserved communities using telementoring to increase workforce capacity. And it uses a hub and spoke structure in which interdisciplinary teams of experts are based at regional and academic medical centers, and those are hubs, using video conferencing technology to engage with local healthcare workforces and other key stakeholders or spokes. And the idea is to share ongoing knowledge, case-based learning, and telementoring. And one of the key aspects of ECHO is that, and what differentiates it from other pipeline training models, is that knowledge doesn't only flow one way. We call this all teach, all learn. And that's a really important aspect of a peer interaction, engagement of local expertise, so that all teach, all learn can be accomplished. And as a result, our collective understanding of how to disseminate and implement best practices across diverse economic and cultural contexts grows. And we see this, the hepatitis C scenario play out all over the world every single day. And diseases that can be treated, but people don't have access to quality and cost-effective health care. So at Project ECHO, our mission is to democratize medical knowledge and get best practice care to underserved people all over the world. This will seem very familiar to you, not only today, but in the last, since everyone has been working from home and sheltering in place. And we have a global, we use simple digital technology. We have a global partnership with Zoom. From those early days, we have grown into a global network where we have partners in 39 countries, 389 partners in 39 countries, treating 74 different disease areas. And our growth, it's really a movement. Our growth, these are the number of hubs each year that we're launching, and over here are the, it really shows kind of exponential growth in terms of the number of learners that we engage. And so really, it's not, one thing I always like to point out is it's not telemedicine, that one-to-one traditional telemedicine, but it's, we call it telementoring, where we're really building capacity. And so the experts, and then in the end, we're able to treat a lot more people and democratize knowledge and share that knowledge. So that's where we were prior to COVID-19. And then COVID-19 happened, and I think took a lot of us by surprise. But we realized at ECHO that we had built this global network and that we had a special role to play in addressing COVID-19. And so we started to galvanize our entire global network and put it toward COVID-19. I'll come back to this URL, but we created a special page for all of the work and to house resources for people. And so currently we have trained over 175,000 healthcare professionals around the world in COVID-19 preparedness and treatment, covering everything from how to distinguish the flu to ventilator settings, all with a local cultural context in mind. But the challenge is that knowledge that the information about COVID-19 is constantly changing, and it needs to get rapidly disseminated and of course adapted to diverse economic and cultural contexts. And we have found, we have galvanized our entire global network, but the demand far exceeds what our capacity is at this point. There's been staggering participant turnout. For example, in Vietnam, we trained over 8,000 clinicians, that's community health workers, nurse practitioners, nurses, primary care physicians, all in one session. Same thing in India, where we trained over 3,000 in one session. And so the need for it is staggering. And with winter fast approaching, and we just heard a little bit about this, but in the global south, underserved populations and vulnerable healthcare systems across the region are at an increase from the pandemic, increased threat from the pandemic. And so that's really what I wanted to share. Now we are, well, there's actually, sorry about that. That's the challenge, and to meet that challenge, we propose to rapidly and significantly expand our existing global ECHO networks. We are currently, but we are building upon our partnerships with the CDC, the World Health Organization, and ministries of health all over Southeast Asia and Africa in particular. And we really to look at adapting existing and emerging guidance on prevention, diagnosis, and treatment of COVID-19. And of course, always, it's really important to work with local partners on the ground to make sure that it has a country or region-specific context. And then we're looking to continue to leverage our global network and then to bring on new and further expand our ECHO partnerships to healthcare providers on COVID-19 using ECHO programs. And so that's really what I had to present. You can find out more. This is the, well, if you take off the /COVID-19, you can, that's just our homepage, but we've created, as I say, specifically for COVID-19, we have across New Mexico, across the United States, and then regionally throughout the world. As I say, we have at this point over 200 programs that are just COVID-19. Many of them have very specific focuses, like, for example, if the network was originally HIV/AIDS in Africa, then it's turned to COVID-19 and then overlaying, you know, that's a community that has an underlying condition, and so they're very concerned about the effects of COVID-19 and treatment for HIV/AIDS as an example. And that you could extrapolate that out to 74 different disease areas, and whether it's mental health, we work with first responders. There are a lot of very innovative programs coming out of this using the ECHO model.
Great. Thank you, Cynthia, for that presentation. Yeah, if we can, if you can post that information into the chat function for people to reach out to you, that would be great. We'll certainly put it on groups.io. And for people to follow on the chat room afterwards, please ask Cynthia questions in the chat room. But for the sake of time, I'd like to move on to our third innovator presenting today, and that is Babylon Health. Is it Claire or Liberty, are you going to be presenting today?
Yeah, hi. Just sharing my screen. Can you see that?
Yes, we can. Looks great.
Perfect. Okay, so yeah, thank you very much, Judd, for the opportunity to present today. I know we've only got a few minutes, so we'll try and keep this quick. I'm Liberty. I'm Social Impact Senior Associate at Babylon, and together with Claire, we're going to talk a bit briefly about how we've been responding to COVID-19. So before we do so, just a quick intro for any of you that don't know Babylon. We're a global digital health company with a mission to increase accessibility and affordability of healthcare. We joined the Innovations in Healthcare Network this year, and we're really looking forward to getting to know more of you in the network and exploring potential collaborations. But now I'll hand over to Claire.
So UK-based company, digital health company, really trying to address people's comprehensive health, making healthcare affordable and accessible. So built really with a kind of the entirety of view of people's healthcare needs from when they're sick, so also supporting people to stay well, and really addressing the whole area of accessibility and affordability by using AI center of what we do, combining that with doctors, nurses, and both virtual consultations as well as physical consultations to give really a comprehensive platform. And Liberty, if we can go to the next one. Just gonna. Yeah, so we started in the UK, started actually as a telemedicine provider initially. We work with both private and government and NGO partners, and actually have a very large platform here in the UK where we're working with the National Health Service. We're also working in the US, in Canada, in Rwanda, which Liberty will talk a little bit about, and working across Southeast Asia as well. We have a modular approach, so we look at health systems, we look at the opportunities, and then sort of fit in our technology and our service depending on what the needs are and how we can best make a contribution and enhance and improve existing health systems. With regard to COVID-19, obviously this type of technology really lends itself very well, and obviously ties in with obviously what other speakers have been talking about. Because we have an app, we have a smartphone app, we are providing a wide range initially of information for people, giving people high quality information, which is available on our app, on YouTube, using social media to really try and funnel the response and the use of clinical resources in the best possible way. So first of all, giving people information. Secondly, we have a highly advanced general health symptom checker, which we have layered a specific COVID flow into. And what that enables to do is to check their symptoms from home, both to check whether they have symptoms for COVID and see how serious those are, but also to give information and reassurance about their other health needs. And coming back to the point that Diana made earlier, obviously really important that people are able to continue to access health services for all the other health needs that they have. We also have then, if people have questions, we can move people onto a live chat function, which enables them to connect with actual people on a live chat. But obviously, somebody can have maybe 4 to 5 conversations at the same time during live chat. So it's a very efficient use of services. For people who do have symptoms and symptoms that can be managed at home, we have an in-app monitoring system where both people advice on self-isolation, on quarantine, on how to interact with others, what sort of tips to manage at home, as well as they can input their temperature and other indicators, and giving them sort of regular reassurance to support them while they have those symptoms. And obviously then escalating where necessary to GPs. And we have obviously a network of GPs that we're across UK, in all the other countries that I mentioned where we're operational. These are working from home. We have obviously centralized booking system. We're still, even with this very high influx of numbers, because we have patients that are both NHS and private, we're able to see people with less than an hour. So because we had those sort of systems already up and running, we're able to obviously manage people's needs, whether COVID or non-COVID related, but from their home, both protecting them as individuals from the risk of going into health facilities, but very importantly, protecting the practitioners from undue risk. And obviously, absolutely as necessary, swift transfer and recommendations to go to hospital on when necessary. So really trying to consider this approach, and I think this really sort of fed into the way and the models that Babylon had already developed, trying to sort of make healthcare more affordable by using AI as the entry point. And our AI obviously is built and managed by both data scientists and clinicians, so it's as well as developers. So it really kind of is maximizing how you use technology, and really then using your healthcare providers only when absolutely needed. So, and then let's talk a bit about how we are adapting this in Rwanda. Yeah,
quickly. So, yeah, obviously what Claire's just gone through is the approach we're taking in UK and elsewhere, which has a slightly different mobile environment than some of the countries in the global south. So in Rwanda, we've developed a solution that kind of works in a context with less connectivity, hardware and resources. So in 2016, we launched Babyl, which is a national digital healthcare service designed for the Rwandan context. And as you can see here, we have over 2 million users currently. We've completed more than 1 million consultations. And in March 2020, we signed a 10-year contract with the government of Rwanda, which is making Babyl's digital health service available to anyone aged 12 and above, covered by the National Community Health Insurance Scheme, which covers approximately 84% of the population. So how does Babyl work? In a normal non-COVID context, this is our model. So a patient in Rwanda, before I go into this, basically should reinforce that Babyl's designed to work on the most basic feature phone, which is the norm in Rwanda. Smartphone penetration is quite low, so this can be used on absolutely any phone. So a patient can register and book an appointment using our simple USSD app by entering *811# into their phone and using the menus to book an appointment. Then they get called back by a triage nurse who does an initial kind of ID verification, which is linked into the government national ID databases. And once verified, the patient does an initial triage to determine whether the patient's symptoms and likely condition are within the scope of digital health. If the patient is eligible for digital health or suitable, then they then get a second call from a GP for a consultation, including diagnosis, advice, and any next step for treatments. If the patient requires a prescription or a lab test, these are issued digitally, so they're sent a SMS code, which is just a random series of numbers and letters that can be then redeemed at a number of health facilities across the country. So those are government-run national health facilities or private pharmacies, and they can take the code and give it to the provider, and they can redeem it there. For the COVID context, we've added 2 new elements to our approach. So firstly, thinking back to the funnel, on the left-hand side here, you can see we've introduced an IVR component. So thinking back to our funnel, the first step was about informing, so making sure people have enough access to high-quality information on coronavirus and what they can do about it. So we already had a customer service helpline that people would call if they needed help to access Babyl, but we've altered this to serve a larger number of people by introducing IVR technology. So a caller can dial 8111 and access a range of pre-recorded messages that answer some of the most frequently asked questions. Whilst callers still have the option to speak to a physical agent on the phone if they don't feel their query's been answered, or obviously they can then make an appointment using our app as usual if they feel it's necessary. The motivation here is to reduce the burden on the helpline and on the doctors and get the information to as many people as possible. The second new element to our approach is on the right, which is about following up with COVID-19 patients. So any patients that have been using Babyl that have reported COVID-related symptoms, if they require clinical monitoring, then our Babyl clinical staff can routinely follow up with these patients. And just to say, as Claire mentioned, beyond COVID-19, Babyl's continuing to remotely support patients with a huge range of health issues. And with the continued spread of the virus, we're seeing a huge demand, both internationally, but also within Rwanda for telemedicine, and the Ministry of Health is really encouraging Rwandans to stay home. And we are seeing an increase in the proportion of people that are using our service that are calling directly themselves from home. So I know we've gone a little over, so we'll wrap up there. And if you'd like to learn more or explore how we could look to incorporate steps of our approach of the funnel into your own COVID responses or broader health, digital health programs, then please do reach out to either of us on the emails below and we'll be happy to talk.
Great. Thank you, Liberty. Thank you, Claire. And thank you to all of our presenters for presenting today. I think we've gone slightly over time, but I think we've fit in everything that we were hoping to share. I just wanted to close out by saying, please fill out your COVID response collaborative participation form. If you have any identified areas of need, you want to propose a solution or champion a solution, serve as a validation site, or serve as a team member or advisor. We would love to hear from you. Also, we want these calls to be useful for you. This is your network. We would love to get your feedback. So write me or Melissa anytime, give us some feedback on format. Actually, we have to work on our time management. Other than that, thank you all for participating. And again, please keep the conversation going on the groups.io platform. Reach out to, we'll leave the contact information for all of our speakers today. Please reach out and continue the conversation. So with that, thank you everyone for participating today, and we will see